My fellow Idahoans, I'm speaking to you today because Idaho is facing a serious situation that must be addressed. Throughout the COVID-19 pandemic, as your governor, I have worked hard to protect the lives and critical healthcare capacity for the entire state, while keeping families safe and businesses and schools open. Every decision has been a balancing act, and while the pandemic response has not been perfect, I do believe we achieved a balance. How can we tell? Because we have managed to prevent a crisis in our hospitals. We have kept our state open longer than almost every other state. Because now, thanks to quick action during the pandemic, Idaho has the strongest economy in the nation and the most financially solvent state budget. With our record budget surplus, we are poised to provide Idahoans historic tax relief and make strategic investments in building Idaho's future for us and our children. Few states can claim that kind of success. We are in the final lap of the pandemic fight. The finish line is close. We are so close to returning to normal. But all that success is threatened by the actions taking place in the legislature right now. Every single state has an active emergency declaration in place to respond to COVID-19. President Trump issued 2 emergency declarations that remain in effect today. When the Teton Dam broke in 1976, during the 1996 Panhandle floods, whenever there's a devastating wildfire, we initiate an emergency declaration at the request of local communities, so Idaho can access critical federal resources we all pay for to overcome the impacts of the crisis. Every time we used emergency declarations appropriately. COVID-19 is no different. An emergency is, quote, a serious, unexpected, and often dangerous situation requiring immediate action. Let me be clear. Undeniably, COVID-19 is an emergency. Hundreds of Idahoans have died and many more have been horribly sick. Many Idahoans still face the same terrible risk. The COVID-19 emergency declaration was requested by Idaho communities, and it is critical in order for Idaho to receive federal assistance, your taxpayer dollars, to manage this crisis. The COVID-19 emergency declaration has enabled us to quickly cut red tape and increase healthcare access. These are the facts. Here is the myth. The emergency declaration somehow shuts down Idaho or takes away your rights. That is patently false. Amazingly, some in the Idaho legislature are perpetuating that myth and actively seeking to end Idaho's COVID-19 emergency declaration. What does that mean for you, the citizens of Idaho? It means less vaccine, more taxes, and more red tape. It means the vaccine rollout is jeopardized, something that is unacceptable in this final stretch of our pandemic fight. It means cities and counties will have to find funds from you to pay for equipment and support they need to battle COVID-19 in your community. It means hospitals could lose access to critical supplies. It means we lose the funding to utilize the Idaho National Guard to support testing, vaccine distribution, food banks, and medical facilities, something that has been a game changer in the pandemic fight. It means we cannot cut red tape and break down regulatory hurdles that stand in the way of better health care access. It means your federal tax dollars go to California, New York, and other states. It means this terrible pandemic and the disruption to your lives will be extended, not ended. Some members of the Idaho legislature are seeking political gain by perpetuating this misinformation about emergency declarations. They are playing politics, and unfortunately the loser in this shameful game will be you, the citizens of Idaho. Members of the Idaho House admit they are not sure of the financial impact of ending the emergency declaration. Why then would you move forward with such a damaging move for our citizens, one that will cost Idaho taxpayers tens of millions of dollars? The Idaho Senate has made it clear they understand the importance of continuing to access federal assistance to overcome the crisis. Why then are you intent on moving forward with an action that will have the opposite effect? I want the people of Idaho to know that I have explained to legislators for months the importance of the emergency declaration and the reasoning behind all the decisions related to the pandemic response. I have sought their input and applied their advice to the state's response. I want the people of Idaho to know that I am firm in my assertion that the actions of the Idaho legislature severely jeopardizes our ability to roll out vaccine and bring the pandemic to an end in Idaho. As I have stated over and over, the no action alternative has never been an option. Pretending there is no COVID-19 emergency, as some in the Idaho legislature are doing right now, will have devastating impacts on our lives, our healthcare heroes who are protecting families and our economy. Those who know me know that I greatly value my legislative partners. Cooperation between the executive and legislative branches is required and expected for those of us in elected office to best serve the people of Idaho. However, the seriousness of this situation demands that I speak up. I believe in my heart that what the Idaho legislature is doing is harmful to our people and wrong for Idaho. I urge my partners in the legislature to stop the political gains and do what is right for the people of Idaho. Abandon the myth that the emergency declaration somehow shuts down Idaho. Abandon the myth that the emergency declaration somehow infringes on your rights. Abandon these irresponsible attempts to undo Idaho's emergency declaration, an action that only puts the lives and livelihoods of our families and neighbors in jeopardy. I don't want to be doing this. I don't want us to focus all this energy on the past 11 months. I want us to focus on the future. We have a bright path ahead of us. Idaho's economy and state budgets are outperforming every other state. We have the strongest economy and the most financially solvent state budget. We have stayed open longer than almost every other state. We absolutely would not be in this phenomenal position right now if we did not have the emergency declarations. If we were not able to act quickly during the darkest months of our pandemic fight. Idaho, I will continue to work hard for you and make responsible decisions that help us get through this crisis together. I would like to introduce General Mike Garshek, the leader of our Idaho National Guard, to explain in more details what is at stake if the emergency declarations go away. General?
Thank you, Governor. Thank you for the opportunity to tell our fellow citizens how much their Idaho Guard has contributed to the health, safety, and security of our state and nation throughout the last year. It has truly been a historic time for the National Guard, both here in Idaho and throughout the entire United States. The Idaho National Guard has deployed to combat operations in Southwest Asia. We fought wildfires in California and responded to civil unrest emergencies in our nation's capital. Right now, over 300 Idaho Guardsmen are returning this weekend after providing security during our nation's presidential inauguration. Here in Idaho, upon the governor's emergency declaration in March, members of the Guard immediately responded to requests for assistance from food banks throughout the state to help those most in need, as well as providing storage and distribution of critical PPE. Since then, our support has expanded to assisting every health district throughout the state, conducting missions such as patient screening, testing, administrative and logistical support, and most recently, distributing and administering the COVID-19 vaccine. I'd like to share a few examples of the Guard's impact throughout this emergency response. At some of the busiest testing locations around the state, Guard support has helped reduce the amount of time it takes to receive a COVID test by nearly 95%, enabling more people to receive a test safer and faster than ever before. Just in the last month, Guardsmen have facilitated nearly 70,000 COVID screenings and tests throughout the state. Guard support has allowed Idaho's most highly trained and skilled healthcare professionals to focus on direct patient care, while our soldiers and airmen carry out many of the COVID-related administrative and support functions, reducing strain on providers and staff, allowing them to deliver the best possible care to our citizens. As I travel throughout the state to observe your Guard in action, the common message from healthcare providers is that the Guard's support has been absolutely essential in enabling them to provide the necessary care and treatment to their patients. It has literally saved lives. We're currently preparing to activate an additional 200 Guardsmen to facilitate the governor's efforts to rapidly distribute and administer the COVID-19 vaccine, making it available to all citizens throughout all areas of Idaho. Currently, every state in the nation is using their National Guard to respond to this emergency. At a moment like this, just as the Guard begins distributing and administering the vaccine, it is not the time to stand down. Canceling Idaho's emergency declaration would do just that. In order for the National Guard to respond to domestic emergencies beyond 72 hours, a formal disaster declaration is required by law. Also, a critical factor to consider is cost. During the emergencies, such as COVID-19 pandemic, an emergency declaration is necessary to receive state and federal disaster response funding. In my opinion, it would be negligent to cancel the emergency declaration at this pivotal moment, denying the citizens of Idaho the necessary support to ensure their health, safety, and welfare. The brave men and women of the Idaho National Guard join to serve the citizens of our state and nation in times of need. They never back down from a challenge, and they truly live up to our motto of always ready, always there. And I'd like to take this opportunity to express my sincere appreciation for the enduring support from our families and employers of our Idaho Guardsmen, without which we could not accomplish our mission. Thank you.
Thank you, General, and please express to all the people on the front line, the Guardsmen and women that are, whether they're in Washington or whether they're out on the front lines or whether they're ready, our sincere thanks. To the people of Idaho, throughout the pandemic, I have endeavored to protect you, your loved ones, and our economic prosperity. I will never relent in that pursuit. I am asking for your help to finish the fight. Please join me. Contact your state legislators and tell them not to take away one of our strongest tools to end this pandemic and get back to normal. Tell them Idahoans' lives and livelihoods depend on it. Thank you.
Meetings, I believe. And next slide, please. So now I'm just going to introduce what we're going to be talking about next in the next group for our future discussion before we start with our presentations for today, just as a preview of what we'll be talking about in future meetings. So next slide, please. And again, we call this group 3. If you look at the CDC, it would be 1C. So we've already done essential workers, as you can see, although we may have some clarifying votes, but we've done that group for the most part, the frontline essential workers. But we still have this other group here, the other essential workers that you see listed here that we have not taken any votes on yet. So that will be upcoming at a future meeting. Next slide shows a little more detail around what we'll be talking about in the future. If you go on to the next slide. So all of the other essential workers and then people in the 16 to 64 age group that have medical conditions that make them at risk will be what we talk about in the future. So again, just giving you a preview of what's to come. Next slide, please. So now we're going to get into our presentations for today, and then we'll do some votes at the end.
It's not your computer. Hi, can people hear me okay?
Yes.
Great, thank you. So I am not at my usual spot. Was in clinic this morning. We just got a little bit overrun. So I'm here with Dr. Davids sharing her screen. So thank you, Dr. Davids, for allowing me to do that. So yeah, I'm just going to give a couple slides to, you all have heard a lot. In fact, I heard something this morning that isn't in my slide. So I'll just verbally mention, you may have heard this morning in the news that Pfizer is thought to be, actually both production lines seem to be lower than had been projected. So there are concerns coming out this morning that we may not be able to increase our I know Sarah Leeds is going to say hopefully we will be seeing increases in our allocation, but a little bit discouraging news this morning on the news in case you heard that. So news keeps coming at us so fast, it's very hard to stay on top of this. Next slide, please. So I just wanted to, just again, kind of summarize what I just said, but also the other thing that's been a challenge, of course, is every state is doing it differently. And we continue to see, this is just headlines I pulled from the last few days as an example, the type of things that we're hearing from around the state. California, that actually, I kind of covered it up accidentally, but that's actually Arnold Schwarzenegger getting his vaccine. You can see in DC, they've prioritized overweight individuals. Some states, this slide in the middle is old. We have now, Idaho has joined many states that are prioritizing older adults, including 65 and older. And so it's really just been a patchwork around the country. Next slide. Want to make you all aware the source of data for the national, where is the vaccine actually been distributed to and where is it getting administered, is this CDC COVID data tracker. Many of you have been using that already to look for data on cases or lab results, but now there's a vaccinations tab you can see there. And you can see there they update regularly. In fact, there was a glitch for a few days, but it seems to be daily now. They're updating the number of distributed and administered doses. And you can see in that little purple graph on the far left there, Pfizer versus Moderna. And Pfizer, of course, had a head start. They got authorized prior to Moderna. So I don't think that reflects an increasing production. It just means that they had got a head start. Next slide, please. Also, we are getting information from our federal pharmacy partnership that you may recall Sarah Leeds told us that, after some discussion and approval that we decided to opt into that federal pharmacy partnership. And you can see here, this is off the Walgreens website. And you can see I've got a little arrow next to Idaho showing the states that whether they had activated that federal program, how many, it's kind of a little misleading, I would say. You see their assigned facilities. So for example, in the left-hand box there, you can see there we have 45 assigned facilities that are skilled nursing facilities. And then the next column there is completed clinics. So you'd say, wow, 45 clinics out of 53 facilities. Well, that's just a single clinic having been held there. Those facilities are still ongoing. They, as you know, these pharmacy programs are doing 3 visits. On the right hand, you can see assisted living. Same thing for Idaho. You can see 118 assigned facilities, and 61 of those have had at least a clinic held at their facility. Next slide. Similarly, CVS is posting their progress on the CVS website. You can see there the numbers are lower for Idaho, but nonetheless, you can track here how many facilities are being taken care of by CVS and how many clinics have been done, both skilled nursing on the left and assisted living on the right. Next slide. So I just want to show you on that CDC site, you can see this is from yesterday morning. So I don't know if it's been updated this morning already, but as of yesterday morning, you can see distribution to the states. So one thing to be aware of is, I think one might presume that it's going to be simply population-based per capita, but it is not. Idaho is 44th in the nation as far as the distribution to our state per 100,000 people. So we're getting fewer than some other states per population. I'm highlighting in this slide Alaska, and I think probably for practical purposes of distribution up to that remote state, they actually have quite a bit more right now than most states as far as how much has been distributed per population basis. Next slide. As far as doses administered, we are 46, not where we want to be. But you'll hear from Sarah some of the progress that we are making in Idaho. You can see here the lowest state right now I'm highlighting is Alabama at 3,384 per 100,000, and the highest is Alaska at 98,000 per 100,000. So they've really been doing an amazingly good job. Next slide. And then a number of people receiving 2 doses reported. There, I wanted to highlight this because I feel like that's somewhere where you can see a lot of states. The states that seem to be struggling a little bit with this are mostly in the southeast. And Idaho there is kind of middle of the pack. So as far as being able to get second doses, I don't know if we're just getting great, I think it's because we're getting great reporting on those second doses from our hospitals and others that have been vaccinating so many of our early doses out to people. But we are in the middle of the pack, and you can see there that West Virginia has really been a leader in this effort of vaccinations and has done a great job. One thing they did in West Virginia different than most other states is they did not use the federal pharmacy partnership, and they vaccinated their own long-term care facility residents, and might be one reason why they're ahead of some of the other states where the federal pharmacy program has been a little bit slower rollout than expected. And you can see there, Ohio is the lowest in the nation right now as far as this measure. Next slide. This is my last slide, and just to lead into what Sarah will be talking about, just yesterday, the Biden administration released their national strategy for the COVID response and pandemic preparedness. You can see some of the key actions there in the web link. It's all over the media, so you should be able to find that. It is a 200-page document, and I skimmed it last night and tried to pull out some of the vaccine stuff. Most of you are aware that the Biden administration plans on taking a much more proactive approach to the pandemic in general and to vaccination in particular, including some federal sites for vaccines, for some other measures, incentives. We're waiting to hear details, but this plan is a great place to start. And with that, I'll turn it over to Sarah.
Thank you, Chris. I wanted to just add that I learned yesterday on a call with CDC and Operation Warp Speed, specifically asking about those lower distribution numbers, because we keep hearing it's pro rata, and they confirmed it's pro rata. But some of the, like for example, I learned that Alaska, because of the remote shipping, got their whole month distribution in one lot, and so that's throwing some numbers off in the map. So hope they maybe put some footnotes in there about that soon. But anyway, so next slide, please. Today, I want to talk with everyone about, give a little bit of update about provider enrollment. And so you all have an idea about how many provider locations we have available for COVID vaccination across the state. Talk a little bit about administration data and show some progress. And then talk a little bit about the state level distribution processes. So that hopefully will feed right into Amy Gamut's presentation of how they're doing it at the local level. So next slide, please. So for provider enrollment, we have currently 310 enrolled providers around the state, and then I have broken that out by district. So 40 enrolled locations and providers in District 1. District 2 has 15 enrolled. District 3, 51. District 4 has 73 enrolled provider locations. District 5 in South Central Idaho has 44 enrolled provider locations. District 6 has 45, and District 7 has 42. So there's a good distribution of enrolled providers around the state. And we also have 49 providers in the process of enrolling. And so they are, working through that process of getting the immunization program, all the pieces of information that are necessary, that are mandated by CDC to be able to receive vaccine. Next slide, please. So these are our most recent numbers as of at the end of yesterday. 82,475 doses have been administered that are showing up in Idaho's Immunization Information System, also known as IRIS. And you can see those second doses. 13,732 people have had both doses of Pfizer and Moderna, and have completed the series, and a total of 68,622 people have been vaccinated. So, we're moving along every week. We seem to have a good jump in the percentage of doses getting administered, and so every week providers are getting a little more efficient and getting those doses in arms. Next slide, please. So here is a calendar of kind of a general calendar of how we allocate doses across the across our processes, let's say. So we are kind of the middleman, so to speak, between CDC, the manufacturers, and the providers who are vaccinating. And so if you look at that first row, every week on Tuesday, we use a planning tool called Tiberius that the federal government provides. And a number of doses shows up in Tiberius for Idaho, and it's an estimated allocation. And we start looking, it's generally, I'd say the past multiple weeks, that number used to change from Tuesday to Wednesday, but lately it has remained the same. So we really begin looking at that number on Tuesday afternoon and planning for how we're going to distribute that across all health districts. By Wednesday, Tiberius, the Operation Warp Speed, confirms that to us. And so we really get serious about how that all those doses will be distributed across all the regions of Idaho. And so we have a meeting. We look at the totals of the populations that you all have prioritized for us. And so in the next, please don't move the slide forward, but in the next slide I'll show you a detailed example of this. But we look at those numbers and divide the doses across the districts as a percentage of the total of the groups that we're working with. And then sometimes, because Pfizer is a minimum shipment of 975 doses and Moderna is a minimum of 100 doses, we may have to round up or down because it won't be an even number. And so we also look at that, like where did we round up last week, who ended up a little tiny bit short. and then we'll round up, and we really look hard at keeping that as equal as possible. We then, by Wednesday evening, share that number with the public health districts, and then they have several days to, look at where they need to get those doses. And then they give that number to us by Sunday or Monday morning first thing, and then we place those orders. And when I talk about this process, I'm referring solely to those first doses, as we bring, those first doses are what enable us to vaccinate new people and add more people to the total that we're vaccinating. Also in that mix on Tuesdays, we get our second dose allocation. So all along, I've been telling everyone, we have, for every dose we get of the first dose, there is a reserved second dose, so that we ensure every person in Idaho, every person across the country gets that second dose that is part of that. It's critical to that series, and are fully immunized against COVID. So we also get that second dose allocation notification, and there's really nothing to decide about that, because that will go where those first doses went, either 3 weeks prior if it's Pfizer, or 4 weeks prior if it's a Moderna dose. So we just look at that and make those orders. They mirror what they were in that time frame prior. And as you look at this calendar, in this the gray area on Tuesday, then it corresponds to Sunday, that second gray box that says second doses are delivered throughout the week in Idaho. So that's kind of the cadence. We are told how many doses are available for shipment for those second doses. We put that order in, and those doses begin arriving throughout the following week. Every once in a while, they show up on the Friday prior, but as a general rule, they come the very next week and are ready for distribution or administration the following week. So all the providers get their doses, those second doses, the week prior, if that makes sense, so that they know they have them and can confirm that all those appointments, those second appointments they've scheduled, they've got the doses to support that. So once local public health departments let us know where they want those first doses to go, we put that order in, and the doses then are delivered either Tuesday, Wednesday, or Thursday of that week. So every Tuesday and Wednesday, we are working with the doses that will be in Idaho the following week. If that makes sense. I think next slide, please. So here is an example, or it's actually what we did this week, but it's 1 week to show you kind of how your decisions at CVAC are really impacting the distribution of the doses. So right now, excuse me, right now we are working with the population's first responders and safety personnel, education, correction and detention staff. We're getting ready for 65 and older. So we look at the totals of, we have staff who help us with population estimates. Dr. Carter's been really instrumental in getting us good population estimates. And so we look at those totals, and then we allocate the doses for each district as a percentage of the total. So as you can see, District 1 this week had 17.2% of the total that we're working with. And District 2 had 7.6%. And so we just go through it like that. And then we look at the numbers of doses we have, round up or round down, and end up with our totals. So consistently the past few weeks, we've had 10,200 doses of Moderna and 10,725 doses of Pfizer. And we track that. It's the fifth Moderna shipment is really that we're kind of counting starting from when the EUA was issued, and that's why those two numbers are off. We had Pfizer the week of that December 14th, and then Moderna came in the week of December 21st. So that's why that says fifth Moderna and sixth Pfizer. So that's really a snapshot of how your critical decisions here are impacting where doses go. And again, we're so grateful for the hard decisions you have to make because they make our job fairly straightforward here. Obviously, again, we're emphasizing that right now, supply is our limiting factor. The demand is far higher than the supply of doses that we have. And as soon as we can get more brands that get approved through an emergency use authorization, we will begin to really have a much more robust inventory in Idaho. Next slide, please. Thank you. So currently, 20,925 primary doses weekly. And then, like I said, a little when I had that calendar up, second doses arrive either 2.5 or 3.5 weeks later, depending on Pfizer or Moderna. So that at that 21-day mark for Pfizer, providers have those for administration, or at 28 days later for Moderna to have them have the inventory on hand to administer those second doses. This next bullet point might change, based on especially what Dr. Hahn said about perhaps the manufacturing is getting slowed down. There's been no changes announced from Operation Warp Speed. We had a meeting with those staff, directly with Idaho yesterday afternoon. Those staff members did not have any new information for us about anything related to doses or processes, and so we do expect them though. As Dr. Hahn put in that new vaccination plan, I think we'll get more information and we will pivot again. So and we'll communicate those changes with you as they come, of course, and the public. So next slide. I think that's my last slide. So I think we're ready for Amy, really.
That's right. We're going to save questions till the end. We'll have about 15 minutes here to hear from Amy, and then after that, whatever time we have left, we'll do questions together.
Okay, thank you. A lot of this will be in addition or mix real well with what Sarah presented. Here we go. So vaccines currently being administered through our priority group 2.1. We're finding that we never continually move through all priority groups. As we get through them, we see stragglers from those earlier priority groups. So it's always just a continuation on, not a completion and starting line. As Sarah already mentioned, many providers are continuing to enroll. This will be very important when vaccine supply increases, and it'll be able to help us, get that vaccine into actual people's arms for sure. Some great news as well. We have some mass vaccination clinics that have already been set up, and a couple of districts have many planned in the future. Reports already coming in, they're very successful. Those mass clinics, they've been able to partner with some other organizations. I know up in northern Idaho, using the Idaho National Guard. A lot of the districts are working with Medical Reserve Corps, and then just working with other enrolled providers in their areas. A lot of those clinics last week were set up with school districts, involving, again, partners and health districts. Early reports are saying that their throughput is as much as could be doubled as what they had staffed for. And so that's great to hear that they'll be able to, in the future, when our groups open up into larger groups, that we'll be able to put more people through those clinics. And then I think last kind of on this slide, just to point out is all the health districts do have strategies in place to reach our rural communities, especially if there isn't any providers in that area to provide vaccine. They're either doing that themselves as the health district or coordinating with somebody else to come in and do that. Some of those smaller communities, we definitely are able to vaccinate quicker through those priority groups. And so that in itself can be challenging. Even within a health district, you could have a county completely through a priority group before another one is. And so that can vary a little bit county to county, city to city throughout the state. And so that has been some challenges there. Next slide, please. So connecting with patients, the first targeted priority groups were fairly easy to connect with and straightforward. The hospitals, for example, we were able to make that single point of contact, provide them with vaccine if they were enrolled, and have them vaccinate, all their healthcare workers. And then even moving into some of those more numbers of healthcare workers, still fairly straightforward, able to connect with them to either connect them with a provider, set them up for an appointment, or let them know where those clinics were available for their staff to come. Currently, just the priority groups that we haven't got to has actually been more of an issue for everybody, not just the health districts, but the providers, just trying to create lists for them, letting them know when their priority group's available. I don't know of any provider that hasn't started a list and developed some sort of process to be able to notify individuals when their priority group is available. Next slide, please. So this is just some challenges, and some of this touched on a little bit that Sarah talked about with limited vaccine supply. It's just transitioning from those smaller, really targeted groups into the larger ones. And so really hoping that we have patients from the public, and this is just an example I put on this slide, priority group, 2.2, around 290,000. We're assuming a small portion of them's already been done, maybe in some of the earlier groups, anywhere from 70 to 80% uptake of vaccine. Even at that, it's still estimated with the current, that weekly allotment to get 10 weeks to get through this group. If it was 100% uptake and none of them have been done, then we're closer to 14 weeks. And so clearly, February 1st, there's going to be limited vaccine and a lot of people that want that. And so, the things that we've done earlier on, hopefully we've made adjustments in some earlier challenges to help prep for this group. But again, it's going to be, last night we were throwing the word around controlled chaos. I hope that we're able to even be better above that. But no, I think it'll be challenging. And then the data entry, I think Sarah touched on this a little bit, because we get a lot of questions about, is vaccine sitting in refrigerators? And some of that is a data entry and reporting. CDC, they report that allocation to the states. That's still those several days before that comes. And then again, when we get vaccine on Tuesday, Wednesday, or Thursday, it might be Friday, Saturday, Sunday, Monday that we're administering those doses, and then it could be into the Tuesday, Wednesday, Thursday, then to get that information into the computer. For the health departments, for the most part, that's very easy. We have an interface that automatically goes into IRIS. For some facilities that don't have that, they're having to hand enter that data entry. And so when I was doing the math on that, it could be as much as a 10 to 14 day lag time. And so when you look at the weekly allocation, you're talking to 30 to 40,000 doses at any time that maybe have been administered, but not necessarily showing up as administered in there. And so not necessarily a challenge, but I guess just more information to let people know that it's challenging to communicate that information out there. And the health districts and providers are all, very eager, yet apprehensive, to move into 2.2. But again, like I said, we've adjusted to early challenges within current clinics to help us, move through that process with these future priority groups. Again, vaccine is the holdback right now. We need more vaccine than what we're receiving every week. I think that's the end of the presentation. I know the health districts or one of their representatives are on, and I think the questions, we're going to come back to all three of us. Is that right?
Absolutely, yes. Yes, thank you, Amy. I think we're ready to open it up to questions now on any of those updates, the national, the state, or the local that Amy just covered for us. And of course, if there are any public health district directors who want to add anything, I encourage you to do that as well. So I'm not seeing any hands up at the moment. So I'm going to ask, oh, actually I do. I was in the wrong place. Dr. Peterman.
Dr. Peterman.
Thank you. Well, it's taken me 9 months to figure out when to mute and unmute. So forgive me if I don't take my hand down. I can't seem to figure that one out. Nevertheless, first of all, thank you to everyone. Anyone on whose phone call is involved in this is, either exhausted or at their wits' end. So to everyone, I appreciate. I have two questions. One is at least as relates to District 3 and District 4, it seemed to us we don't get information on our allocation till Friday or the weekend, and so what that means is, as we schedule out going forward, we have to limit scheduling. Again, we're like everyone else. We could double the number we're doing. So that's number one. I'm not quite sure why that is. And the second, if I understand, and I think this is important for the public to hear, it appears that there are 30 or 40,000 doses that somewhere is not being given. But I think what you're saying is it's just a delay in reporting. And if that's the case, I think that's very important to get out to the public. Thank you.
Thank you, Dr. Peterman. And I think for hands down, I think you just press on the hand again. I don't ever get to put my hand up, so I'm not sure, but I'm pretty sure. All right, who would like to take those questions? The first one about District 3 and 4, when you get your allocation information, and then the delay in doses being reported.
I can't talk about 3 and 4, but I can talk about, the doses. Again, that's just some speculation as well, just working with some of our local providers, and the reports of them having some challenges to get that data into IRIS. I don't know that 100% for sure that that's all of that, and there's not vaccines sitting somewhere, but at least for our district, I think that's what we're seeing.
Thanks, Amy. And what about the District 3 and 4?
This is Elke. I can add a little bit more in terms of the doses administered, and some additional information that we're hearing as well is that some of the providers, while it might show as a dose not administered, it might be doses that they are reserving for larger clinics, for example. So until they actually perform those clinics, we might not see them into IRIS for a period of time. So lag time can be kind of interpreted broadly if you think about it from that context, but we have heard some of those things as well.
Great, thank you, Elke. What about the allocation timing, the communication of the allocation timing? First part of Dr. Peterman's question. Who could answer that for us?
Monica, this is Jamie Annenson. I'm at District 3 and I'm sitting in for Nikki Zog.
Great.
And we are aware of some communication gaps and are actively working on that to get the information out faster to our providers on our dissemination plans.
Great, thank you, Jamie. Let's go to our next. Well, first of all, I see that there is a lot going on in the chat, and we're going to come to the questions first, the live questions first, because the chat we can try to follow up later. But I do encourage you, if you have something you'd like to make sure that we hear together during the meeting, if you put your hand up, that works really well. So I'd like to go to Christine Newhoff next, please.
Thank you. I hope I'm effectively unmuted. I had myself muted in 2 places. Can you hear me?
Yes, we can. Thank you.
Okay, great. Well, just a couple of questions. So, as we were talking about or hearing the presentation about vaccine being distributed among the providers and providers reaching out to patients, I think that will help address part of the population that we're looking at vaccinating as we move forward, but to rely on providers to do the targeted communication is going to potentially leave a gap relating to people who don't have a primary care provider or who haven't been seen in a hospital or health system. optimize the number of people who not just know that appointments are available, but actually have some enthusiasm and or sense of urgency built around getting the vaccine, so that we're able to actually achieve having a high percentage of our population vaccinated, and not just get to the end of the effort and say, well, we made enough doses available, but people didn't seem to want it. So the one question is, are we taking steps to develop that kind of a program beyond social media and website and news conferences? Are we targeting communications to populations and thinking about how we bring that to the people that we need to get vaccinated? And then the other question I had relates to our goal. And should we or do we have a goal to have a certain percentage, or everyone who wants to be vaccinated on a certain timeline? So, for example, recognizing we're not yet receiving the doses to be able to do it, would start of school in the fall be the right target for having people vaccinated? And I'm sorry, I'll ask all three of my questions at once so that we have to go back and forth. And the third question is, are there states who have already maybe put together, or places that have already put together a program for reaching out to communities and trying to maximize the number of people in those various populations who would get the vaccine? And if so, is there information that we could gather and learn from? Thank you.
Could you please repeat just the very last part of your last sentence or two, because the audio is a little tough to hear.
Oh, okay. Sorry about that. Yeah, the last one is if there are other states or locations that have put together a comprehensive plan for how to target populations and maximize their uptake of vaccine, is that information that could be gathered that we could learn from?
Perfect. Okay, thank you, Christine. So we have 3 questions there. Elke, it looks like you're ready to answer at least part of that.
Yeah. So all great questions and input, Chrissy, we appreciate it. And I think when we get to the end of today's today's meeting, one of the things I do want to do is solicit this type of questions and comments and things that we can bring more comprehensively to you in the next meeting, because I know that there are a lot. Clearly, the chat, there's a lot of questions and comments going on. But to try to get to some of your questions right now, regarding outreach, targeted communications, what we're doing around that, which sort of ties to your third question as well. We do have some significant work that's underway right now between the department and the governor's office, and making sure we're really looking at how we get messages out to populations on a variety of topics. One of those will be making sure that we do more around recruiting the priority groups that are up for vaccines. So we're working on the statewide level approach, but I do know that the districts also, have their own kind of communications and marketing efforts that they're doing locally to make sure people are aware when it's their time, and then how they go about getting signed up. So more to come on that. So maybe we can bring that information to you next time. I'll give you a deeper dive on what's happening. Your second question about kind of the overall goal, we've participated I have participated in meetings throughout the course of the week with each of the regional providers and the health districts. And I know that locally there are different areas that have their goals as well. We've heard, for example, every dose will be in a person's arm within 7 days. And so I wanted to make sure that we had some coordination across the health districts and us as well, in what a goal should be for us to set as a target. So I'm bringing more on that next time as well. And then in terms of states that have put together a comprehensive plan to target populations, absolutely, we can reach out to we're in constant contact with states. And so we'll do some research on that, and I will then turn it over and see if staff have anything else they'd like to add on any 3 of those items.
Anything else to add at this time? All right, we'll leave it at that for now. We have a few minutes. We have 5 minutes for questions. So let's see how many we can hear from in the next 5 minutes here. And again, anything that we can't get to, please put it in the chat so we can take a look at that later on. I don't see any hands up, any new hands up at the moment. So I'm going to turn it over to Kathy, Dr. Turner, and Dr. Hahn. Do you see any themes in those questions that we could bring forward right now?
Yeah, thanks, Monica. This is Kathy. One of the we took care of some questions about targeting certain populations, so I think we've got those covered. There was a question. This was from Daryl Anderson about whether or not we are set up to handle an increase in allocations, so there's not a delay in getting them administered. And Dr. Hahn did answer in the chat, but just so everybody else knows the answer, for those of you who are not watching the chat, we are continuing to increase the number of providers that are enrolled in the program. And so our capacity to vaccinate more people is going up every single day. So I don't think that is not a limiting factor from the perspective of either the state or the public health districts. But of course, we do have our public health districts on this call, so they are more than welcome to chime in with that. And then we did have a question about the average time between when a vaccine is delivered to a provider and when is it administered. And that, I think, is a great question, and we will get back with the members with some additional data either in between meetings or at the next meeting.
Thank you, Kathy. Is there anything else at this time that would be helpful to bring forward? And thank you so much for answering questions as much as you can as we go through in the chat.
So I guess I would just add on the capacity. Yeah, I know we have multiple providers that are ready and willing, just waiting for the vaccine. So I know the capacity is there to move it through when the allocations are higher.
Thank you, Amy. All right, I'm not seeing any hands up at the moment still. Anything else, Dr. Turner, Dr. Hahn, that we could bring forward to the group right now?
No, Monica, I think we're good from the chat perspective.
Excellent. Very good. Thank you, everyone. That was a lot of updates. Thank you to Dr. Hahn, Sarah, Amy for those great updates and for your questions as we all get a common understanding of what's going on and what's coming with regard to planning, distribution, administration, and all those very important topics. I think we're ready now.
Monica, this is Amy. Sorry, let me add one more thing, because I actually didn't put it in our slides, but we were looking at what we could move up to per districts. And I know some of those districts, we're up to, 20,000 in a week. So I know we have large capacity ability when the time is ready and the vaccine's available. So I just wanted to add that we're already looking at those numbers.
Excellent. Thank you so much.
Monica?
Yeah.
I'm sorry. This is Chris Hahn. And you asked if there were any more questions, and Kathy said no, and then two good ones just popped in.
All right. Well, we have 2 perfect minutes for that right now.
Perfect. Okay. The first one is whether hospitals or providers should use their second dose allocations as first doses. So I want to make sure that question gets answered. Sarah, do you want to address that? This comes from Karen Cabell at Kootenai about whether they should be using their second dose allocations as first doses.
Not as a general rule, no. There are a few instances where there's inventory that you may use first that was your, if it's your dose one, but that we should probably take this offline. I don't want to confuse people. Dose 1, we know you have dose 2 coming. So if that makes sense, just always know that if you are vaccinating a person, there's a reserved dose coming either 2.5, 3.5 weeks later, depending on Pfizer or Moderna. But if there are some inventory, there are some ways you should have your staff. If there are questions about just using it up first, please have your staff contact our vaccine operations staff, vaccine management staff, because they can help you decide that. But as a general rule, dose 1 should be dose 1, dose 2 is coming.
Yeah, thank you, Sarah. And I'll just clarify again, part of this question might have come out of how in the United Kingdom, for example, they recommended taking those second dose allocations and actually using them to start vaccinating more people. In the United States, the priority continues to be everybody who gets a first dose should get a second dose. So don't ever put those second doses at risk. You want to make sure that your patients that got a first dose get a second dose. And then, like Sarah said, if there's some extenuating circumstances, leftover second doses, because some people aren't going to get a second dose, then you work with your health district to make sure you're reallocating correctly. Okay, I know we only had a short period of time, and there was a second good question up there. Now it's kind of way up in the chat somewhere. I think this is the one I think from Katie Quinn. Our districts assessing throughout throughput based on their vaccine provider capacity. Amy, I think that'd probably be for you.
Yeah, I just added that in the chat that I was hoping that I answered that. So yes, we are looking at that. And we actually were going to actually present that today. We did not because we didn't quite get that for everybody. But no, looking at it closely. And again, some of those early clinics, those estimates are actually even going to be higher on throughput. So we're doing a great job getting people through. So yes, I think those will continue to evolve as we move through the groups.
Great, thank you.
Thank you, everybody. And thank you for everyone helping manage the chat and bring questions and answer questions. That's very helpful. Now we are ready to turn to our Idaho priority subgroups discussion and votes with Elke and Dr. Burgess.
Great, thank you very much. So I wanted to just reinforce a couple of things as we move into the next section of our work here today. One is that we've really been focusing on what we're calling Idaho's Group 1 and Group 2. You all took action to vote on some clarifications on Group 1 and Group 2, and Dr. Burgess reviewed those with you at the beginning of the presentation, or earlier on in today's meeting, I should say. And then we have a few more votes. We have 4 more votes that we need to solicit from you to take us through the remainder of Group 1 and 2. And all of those votes combined between the ones that you did online and the ones that you'll do today, we have scheduled time with the governor today to review those. And just as a reminder, all of our voting that we do from CVAC goes to the governor for his final decision. And Dr. Burgess will lead you through the actual voting process. The next slide, please. Wanted to remind you as we're walking through our votes, just reminders about what our guiding principles are, our goals, and other considerations we need to take into consideration. And it was very redundant what I just said. But as a reminder, we have our goals here on the screen that we've had. Our considerations are, of course, as you just heard over and over again, is about limited vaccine supply. We've talked in the past about epidemiological data, as well as the logistics that may come into play. If you recall last meeting, Dr. Turner did a really in-depth dive on the epidemiology of this Group 1 and 2. So with that, we're going to move forward. I'm going to turn it over to Dr. Burgess.
So like our previous votes, we've prepared the options for you that you'll see in a familiar format coming up, and we'll have an opportunity to discuss and then vote. And if we have a clear majority, which we have so far had, then that will be the decision. If we can't get it obvious, we'll have some discussion and revote. And if we still can't get it figured out, then it will just go to the governor and he'll see all of our votes and our discussion, so he'll have all that information to help him be the final decision maker. So that's kind of how that process will work, just like we've done in recent meetings. Next slide, please. So before we go into our actual votes, remember last meeting we decided to go ahead and allow categorization if it was already really clear in CDC or CISA guidance. And so we just wanted to show you some of those decisions that were just very clear and were already automatically assigned. So for example, healthcare students that are doing rotations in clinical settings are included in healthcare personnel. So that was a very clear recommendation or categorization that we just adopted. And then again, you see here in outpatient and inpatient medical staff, we have some categories of people that are unable to telework. So substance abuse treatment providers, physical therapists and assistants, eye bank workers, speech pathologists, and pediatric home health providers. So those are all automatically categorized in that group. And then the final couple here are first responders, including search and rescue team members, TSA workers, and animal control officers, and then public transit workers, including regional transit bus drivers. So again, these were clearly delineated by the CDC or CISA and are automatically assigned because of that. So next slide. So now we're going to talk about the ones that are not clearly defined anywhere else, so we have to make a decision. So we have, I think it's 4 votes, maybe 5, we'll find out. So the first one is regarding clergy, and the question is, do we want to have clergy that enter healthcare facilities or provide religious support to patients? So these are folks that might come in to give last rites, for example, either you know, in a healthcare facility or in someone's home that the patient is near death. And the question is, do we want to include them in this healthcare personnel category? So I will open that up for discussion before we take a vote. Are there any questions or discussions around this group?
I see that Karen Echevarria has her hand up, and I think Christine's hand up was from earlier, but if we're mistaken there, let us know, Christine. But we'll go to Karen, please.
So my question would be, how do we delineate between clergy that enter hospitals and clergy that don't? You know, because when you make the call, you don't know which priest is going to come to the hospital or which minister is going to come. So how do we delineate between those two?
Well, I will take a stab at that, but then I'll defer to others that might want to elaborate. You know, there's been a discussion both statewide and nationally that at some point we have a little bit of the honor system, you know, and I realize that's not perfect, but I do think, you know, we can obviously ask for identification for employment, but as far as whether they go in are going to be honest to us, I don't know how we can police that, but I'll see if anybody else has a comment.
That's Dr. Burgess said, this is Elke. That's how we have been kind of moving through this whole process, that, you know, we're hopeful that people are honest and you know, coming in when it's their assigned time. I also want to clarify too that this, for some reason, when we put this up on the PowerPoint, the blue line is really to show that this request is, this clarification is for this entire slide, because clergy might enter healthcare facilities, either hospital, long-term care, other types of settings. So it came up on screen, it sort of moved things around slightly. So I just wanted to point that out.
Great, thank you. We had a comment from Dr. Hudspeth. You might want to take a look at it in the chat about this particular group. Dr. Burgess, go right ahead.
I'm sorry, do you have any, you don't have any raised hands?
We don't have any new raised hands. I'm going to guess that Karen's hand is up from previously.
And then anything else in the chat besides Dr. Hudspeth's wonderful comment?
Anything else in there?
No, Monica, just that comment.
Excellent, thank you. I was
all
thinking.
Right, so I believe we are ready to vote. And remember your little megaphone over there. You can click yes or no, whether you want this group to be included. And please do that now.
And as a reminder, it's voting members only.
Correct, thank you so much.
All right, I'm taking a look at the results coming in. Well, our numbers are slowing down, and I think we are safe to call it at this point. We might get a few more coming in, but we have 26 yeses, 0 nos.
All right. Thank you very much. So we will move on to the next group, our next vote, excuse me. Next slide. Thank you. So this is under the community support area in category 2 here. And the question is, do we want to clarify or include foster parents under community support? And where this comes up, that's been described to me, and I'll let somebody else add if I don't get it right, is there are circumstances where there's an emergency need for a child to be placed in foster care, and that child is coming from an environment where it's unknown whether they have been exposed or might be COVID positive, and the foster parents are asked to take a child or more children in. And so if they had access to vaccine, they would feel more safe in doing that. So that's my understanding. Anybody else wants to add to that, feel free, and I'll open it up for discussion.
I think you captured the intent of that very well.
I guess the one thing I didn't, and I hate to say this because I might put somebody on the spot, I don't really know the numbers, and we didn't really talk about that with clergy either. I think, you know, it might be hard to estimate how many clergy do last rites, and I don't know if we can estimate foster parents either.
And we did I see that question in the chat as well from Mal Leviton about the numbers. If anyone has information on that, feel free to provide that or at this time. But I don't see any hands up. And Dr. Turner, Dr. Hahn, anything else in the chat we should bring forward on this this question?
No, Monica, nothing aside from what the number of the population might be.
Okay. All right. Thank you. Well, with that, should we?
Yeah, I don't know if we have quick access to that information, it sounds like. We will have to do our best to take a vote. I'm sorry.
This is Chris, and I put a note in the chat that I'm not sure is visible, but there are 1,242 licensed foster homes in Idaho. The number of parents in each home is, I don't have that information. You could assume 2, and then of course those people who are the foster parents might be falling into other groups as well for vaccination, but that gives you some sense of what might be needed.
Thank you very much. I did not see that in the chat, so thank you for highlighting that. So somewhere in the 2,000-ish range, if you double that number. Any other questions or hands raised or comments in the chat?
Dr. Wyatt has her hand up.
Dr. Wyatt?
Yes, I just wanted to remind everybody that we do have the option to be able to test children too. And so there is some control, even though the testing is not perfect, there is still some control to potentially protect those foster parents without necessarily putting them directly in the vaccination group. So.
Thank you. And I don't see any new hands up this time. Any other comments?
So I see, did we clear the vote from the last time?
Yes, we did.
Great.
Okay. All right. So it sounds like we're ready to vote for this time. So go ahead and click your little yes or no button.
I'm sorry, Elizabeth Wakeman has her hand up.
Oh, there we go. Thank you. Oh, we have, all right.
I can't confirm this, but I believe I read that recruitment of foster parents is a problem. If they can't get vaccinated, they're not willing to serve. And we have a shortage of foster parents in the state, all over the country, really.
Dr. Wakeman, that is also something that I have heard.
Do we want to clear and re-vote, or what do we want to do? Because I think some people had voted before the last 2 or 3 comments.
Why don't we go ahead, Natalie, if you can do that, if the voting members don't mind to submit their votes again, just to make sure we're doing this in a coordinated fashion at the same time. So we're going to clear that vote. If you've already voted, we're going to ask you to vote again on this particular question on the screen. And I think let me see, no more hands up at this time. I think we're ready to go ahead with the vote on this. This one's not quite as clear, so I'm going to wait a few more seconds here. All right, I think we can announce it at this point. Right now, we're seeing 12 yeses, 14 nos.
Okay, so this is an example we talked about where if it wasn't clear, we'd have a little bit more discussion, take one more vote, and if we can't come to a majority, we'll leave it to the governor's decision. So I think one of the comments about testing, can anybody say if that's occurring now, if we have the ability to test children in these circumstances? From what I understand, sometimes it's a rather urgent situation where children are moved from a home and need to be placed in a fairly short notice. So does anybody know about that testing option?
Does anyone have more information about that?
And then there's a comment, and I can wait for the chat people to.
Yeah, thanks, Patrice. There is a chat question that asking, are we having problems placing COVID positive children into foster care? And I don't know if anybody on the call knows that answer either.
This is Elke, I'm going to put Dr. Chris Carter on the spot, as I know that she receives a lot of the input that comes in, and I don't know if there was any further clarification that came with this or those requests for foster parents.
Dr. Carter?
Sorry, double muted. Primarily, the consideration was that foster parents were afraid that if they accepted a child in need, that they could be exposed and be putting them at risk. I have no information about placement of COVID positive children.
Thank you, Dr. Carter. I see a couple of hands up. Elizabeth Wakeman, Dr. Wakeman, is your hand up? New?
It's a new one.
Just
New
check.
hand.
Thank
Yeah,
you.
I was a foster parent for 10 years. And when kids are, so I don't have anything about recent, I just have from the past. Kids are often taken very quickly and they have to be put somewhere. And if they're not put in a home, then they're put in a group facility. And it's unclear to me how you could possibly be testing kids and keep them quarantined from other kids who are moving in and out of group facilities. So even if they tested negative at one point, the time between the test and when the test results come back, they're being exposed to other kids who have been in pretty traumatic and chaotic circumstances. So I know from the foster parent perspective, I very much understand an unwillingness, if I had any health risks, to be taking in kids that I don't believe you could test reliably before you put them in a house.
Monica, we also have a hands up from Yvonne Ketchum.
Yes, thank you.
Before we do that, Monica, what was the vote from the original vote?
The vote was, let me go back to my note
12
here.
yeses and 14 nos.
That's right. Thank you.
I'm sorry, what?
12 yes and 14 no.
Okay, so we did have technically a majority on the no's, but just a closer vote than usual. Yeah. Okay. Next hand up. I'm sorry, go ahead.
Yvonne Ketchum-Ward, please go ahead.
So could I ask for a little bit of clarification? Putting the foster parents, prioritizing them is important, but it's hard to see where they're going to go, who they're going in front of. So it looks like foster parents would be in with teachers, but I'm getting concerned about the number of vaccines and getting to our 65, 75 years and older. So the screen is a little bit covered on the 2.2s and 2.3. So it would help me if we clarified who are we putting the foster parents in front of, more than is it just right to vaccinate foster parents, because it is, but I want to know who those 1,000 plus would go in front of.
I can clarify that, what's behind those boxes on the screen. So the request is that they be added to the overall category of 2.1. And if you recall from the governor's announcement of his prioritization of frontline essential workers and adults aged 65 years and older, first responders and safety, so that first line that you can see on here, is one of the groups being vaccinated now. Also included is pre-K through 12 school staff and teachers and daycare and childcare workers. It's the second portion of 2.1, and the third portion that you can't see is correctional detention facility staff. So those three 2.1 groups are going right now, and then the line after that is age 65 and older. So this request is asking that they be placed in that tier just above age 65 and older. That consists of sort of three groups. Does that help, Yvonne?
Yes, thank you very much.
Mm-hmm.
Great, thank you. Let's go to Amy Gamet, has her hand up.
And this just kind of tags on to an earlier comment. So it's just I would like to be able to vaccinate everybody, but we're still trying to get out to law enforcement, policemen, firemen at the same time. So I don't know if that's going to push some of those groups out farther.
Right, who could address that?
My understanding is that they'd be in the same group as them, not ahead of them, right?
Right, they'd be in the same group, just limited vaccine doesn't mean everybody in that group's being vaccinated at the same time.
So would that be a correct assumption?
Yes, that they would be at the same time as law enforcement.
Okay, thank you. Thank you. I see Mel Leviton has her hand up. Go ahead, Mel.
Yeah, I just want to tag on to the comment that was in the chat. I mean, I guess I would, when we made the distinction of adult and child protective services and child welfare workers, I guess my interpretation of that in my head was people who were providing crisis foster care or therapeutic foster care would be in that number, but all foster homes don't accept crisis placement, and all foster homes are not accepting new children. So I just wonder if there isn't a way for the department to make that distinction. You know who those homes are, or the people who deal with child welfare know who those homes are, and to include that group of people in with the child protective services group, because I don't think that number ranges in the 2000s. And I agree, the more people we keep piling into the list early on, the longer it's going to take for people who have chronic health conditions who are after the 65 plus group. So I just, that's what concerns me, is the greater these numbers get. So let's not do everybody. Let's do the foster homes that take crisis kids, crisis placements. That's my 2 cents.
Thank you, Mel. It's a good distinction. All right. I don't see any other hands up at the moment, unless Amy's a new hand.
Nope, sorry.
No problem. Just want to
So
make sure.
I want to make one thing clear before we finish this discussion is, this goes to the governor, right? And he makes the final decision. So he will see our original vote actually did come out with a majority. It was a very small majority. So I made the decision to have further discussion just because most of our votes have been more clear. But he will see all of that and have that information available to him. And there's, obviously all of these points are very valid. These are tough decisions. And then when you were talking about crisis workers, they are already listed here, right? I guess child welfare workers. So I don't know if there's any overlap in that department, but there's some more comments in the chat. Is anything that we need to bring forward, Dr. Turner?
Yeah, Dr. Burgess, I just wanted to bring to the surface for people who are not monitoring chat or people who might be on their phones or that sort of thing is that there are other things we can do to assist foster parents. For instance, there's been some chat back and forth about working with the agencies to make sure they have rapid antigen tests available that can be done very quickly. I think there's some other solutions to some of the challenges that have been brought up that that we will talk about behind the scenes. And then there was a question. I don't know if we can talk about it right now about education. So I'm going to leave it to you to decide whether or not we want to go into a different category of discussion or stick here for now.
Yeah, I think we need to complete the votes that we have, and then we can come back to that. It looks like we hopefully will have time. So,
thank you.
All right. Well, I'm not seeing any more hands up at this point, and I think it sounds like we've captured most of the questions here or the chat comments here. I see something from Dr. Hudspeth in there as well. So we've had a few more points to consider in this discussion. Dr. Burgess, where would you like to take us next?
Well, anything else anybody wants to summarize from the chat? Because I do worry that not everybody reads it, and there are some good comments in there. But I also, again, the governor will see that our original vote was the way it was. We can take one more vote because it was so close after all this discussion, and then we'll move on and send him all of that information so he has it to review. So again, if there's nothing else to discuss, I would ask you to go to your little megaphone and do a yes or no vote on the same category, which we've already been talking about. Just, do we want foster parents in this community support portion of first responders? So yes or no.
All right. Well, I think we have a clear answer. We have 3 yeses, 23 nos.
All right, and that agreed with our first vote, only more forcefully. So, okay, next slide, please.
My apologies. Can you say the vote numbers again? Sorry, missed it.
It was 3 yes and 23 no, I believe. Is that right?
Correct.
Okay, great. Thank you.
Okay. All right, so now we have another clarification in that same category under first responders. Do we want to clarify that there's a subset of gas, electric, and water utility workers, so energy workers, who respond to emergencies? For example, power's down, main water line's broken. Do we want them to be in the first responder category? And I hate to ask this because I don't know if we've done this, but do we know numbers for that group? Sorry. I'm assuming it's not a huge number.
Hi, this is Chris, and for electric company, Idaho Power puts about 530 in that group. For Bureau of Labor statistics, for gas, there's about 300 total, so that isn't broken down to a subset. And for water and wastewater, with Bureau and Labor Statistics, it's about 662 total, so it'd be a subset of that. But that subset I have no data on.
So if I'm adding right, that was 1,000 to 1,500, but probably less than that if you look at the, does that sound about right?
Raise my hand. Oh, can I raise your hand?
I think so from the
Yeah,
numbers.
it's about 1,000.
Okay. So let's discuss this group. These are folks that respond to power outages or water lines broken or an emergency with gas, a similar emergency. So discussion, either hands and or chat.
Dr. Davids has her hand up, or it might be Dr. Hahn, I'm not sure.
Yeah. Yeah, thank you, Monica. That's right. This is Dr. Hahn. I just want to comment that the CDC's definition of frontline essential workers did incorporate the concept that frontline means interfacing at high risk themselves of getting exposed because of their interactions with other people. So there's the broad category of essential workers that help keep society going and economy going and so forth. But frontline, at least the way that it was initially defined and envisioned in the CDC's vote, the ACIP's vote, is that they are also at increased risk of exposure because of their interacting so frequently with the public. So I just want to make that comment to help set the discussion.
Thank you.
Thank you very much. That's helpful. Other hands raised? Monica?
I don't see any other hands, unless Dr.
Okay,
Davids wanted to say something.
But
chat. Kathy, Dr. Turner, is there anything in the chat we can bring forward here?
Yeah, so it certainly ties into what Dr. Hahn just mentioned. There were some questions about what kind of exposures this group has. The assumption that they work mostly outside, have limited contact if they go inside. And so I think that's the assumption. If there needs to be clarification or people know exactly what this work environment looks like, it might be worth clarifying a little bit.
All right. Great, thank you. We're hearing a little bit of background noise, so if everyone could just check their mutes really quick, just in case. And let me see. Daryl Anderson has his hand up. Go ahead, Daryl.
Hopefully you can hear me. I'm not on a great connection, but I just thought I'd speak to it since I have worked in this business in the past. And I think what they're asking for there are the truly frontline folks that do keep the lights on. It's not the administrative folks, it's the people that get systems up and running. And to the point, they do have exposure to the public. When you have an outage at times, they're working with homeowners from time to time. So they are out there in front of at time, but they do work outside. They're also people that cannot work from home. And so we talk about all those things. So I think the Idaho power number was brought up was about 530. I think that's about right. Probably a little bit less than that. If you really try to focus on those, total is probably about 1,000 across the state of Idaho when you talk about electric and water. And if we're going to use the notion that they work outside or they do those things, there's a lot of people on this list under 2.1 that are in that same boat. And so if you start using that sort of criteria, or are they truly frontline essential workers? I know ACIP had been asked to look at this. I don't know if they looked at it in this last week, but it is these are pretty critical people that if we talk about one of the goals of this group was to recover functioning of society and the economy, and if you get your energy folks who get sick and ill, then you're going to have an impact on recover functioning of society, because they are essential services that we all can't live without. So that's the reason I think that ask has been made, whether it's electric, gas, or water, and those are things that we can't live without. So that's why it's put out there. So I would be careful about saying, are they outside workers or not outside workers? Because there's a lot of people on this that may not meet that same criteria from my perspective. But thanks for allowing me a chance to chat.
Absolutely.
Thank you. And Monica, I have a request. if we could clear the votes, and please don't vote until I call for the vote, because we can see your vote, and then it might influence people while they're still having a discussion, and I would rather have us vote after our discussions are complete. Thank you. So any other hands up?
I don't see any hands up at this time. Any other
Thank you.
comments in the
Anything
chat? Sorry.
So no comments in the chat other than some agreement with comments made by Daryl.
Okay, very good.
Okay, so I think hopefully we've had enough opportunity to discuss. And please now go to your megaphone and vote yes or no for this group.
And I'll just verify that I did see that it was cleared just before we started this vote.
Yeah,
so.
I did see it clear. Yeah, thank you.
Very good. I think we're getting very close.
And I think we have one more group, and then we should have time to talk about some of the questions that came up in the chat that we had to delay or couldn't address at the time.
Okay. And I am adding one more vote for someone who is not able to vote actively here. So I'll just let you know if the numbers vary. That's why. So with that additional voter, we have 8 yeses and 18 nos.
Okay. So that seems like a clear majority. So let's move on to, I think, our last vote that we've teed up for today, and then we'll have time to discuss some other things. So this is, again, in the same group, frontline essential workers. And the question is, do we add, under U.S. Postal Service workers, do we also add non-USPS package delivery services, such as UPS, FedEx, Amazon Prime, in that same category? So I'm going to open that up for discussion. And I apologize. I don't know if we have numbers on that group, those groups.
Dr. Carter,
yeah,
if you're
this
with
is
us.
Chris. For non-USPS package delivery services, which includes FedEx, DHL, World Courier, UPS, it's about 3,398 according to Bureau of Labor Statistics.
Great, thank you.
Thank you. Thank you.
Excellent.
Any discussion on this category? Hands up or chat?
I do see a hands up. Yvonne Ketchum-Ward, please go ahead.
Will we really be able to separate out an Amazon delivery person versus like the new Amazon plant in Nampa? I know it's an honor system, so we're only talking about the Amazon the person who delivers your package, just like a U.S. Postal Service worker would deliver your package. That's a clarifying question.
Well, it says package delivery services, so that would be my read, unless somebody reads it differently.
Okay.
All right, I'll read it that way then.
All right, that's how we're going to perceive it together. Thank you. And then let's take a look at the chat. Dr. Turner, I'm seeing a couple things flash by, but I know you're monitoring carefully.
Yeah, thanks, Monica. So it looks like the question is, do these people have that much face-to-face, or are they basically door drop-off without interactions? And then Chris Carter noted that USPS has a universal service obligations. And Dr. Carter, you might need to explain what that means.
Mm-hmm.
It is basically a obligation that they have to serve. Everybody receives the mail service. So that's because I've been struggling with why they were called out separately from other groups, and I believe that it is because of that universal service obligation. They are required to deliver. They have to deliver to areas, whereas other services can choose that they do not want to deliver someplace because it's not beneficial for their company.
Okay, thank you for that clarification. Anything else in the chat?
No, not. The question was, as federal employees, are USPS covered elsewhere?
No.
Thank you.
Thank you. That was clear. Anyone else? I don't see any other activity in the chat since that last comment right now. I don't see any hands. So
okay, let's proceed to a vote here. Please go vote yes or no for this group.
we'll wait a few more seconds, but I think it's going to be very clear. All right, I'll go ahead and announce it. We have 0 yeses and 26 noes.
All right, I think our vaccine allocation slide at the beginning made it clear that we have limited supply. So now I think that's the last of these slides. Is that correct?
That is correct.
Okay, so I heard in the chat we wanted to go back and talk about a couple of things. I'm going to have to rely on whoever was monitoring that.
Yeah, thanks, Dr. Burgess. This is Kathy. There was, I'm so sorry. It was
education.
Yeah, thank you. So the question was related to school board members, and are they included in that group? I don't know. We should probably look at the slide that has group 2.1 on it. They are in school buildings every week, and we need to have some clarification because we're not sure that's being applied the same way across the state.
Do we have a clean slide that doesn't have the vote?
Natalie, it would have to be in our combined opening slides on.
There it is.
That looks good.
Oh,
that's perfect.
Okay. Okay, so we're talking about this education slide, pre-K-12 school staff and teachers. Am I correct? That's
Yep.
the group we're talking about? Okay.
Yeah, I assume so.
So what somebody's asking is maybe some districts are including board members under staff and others are not. Is that the
question was, do we need more clarification there?
And this is okay. I did reply back to Karen on that comment, but I realized I did it privately on accident. That is certainly an area where, since it's already being applied, some districts are saying yes, some are saying no, that we can clarify that directly with the districts, or we can bring that further clarification through this group.
Thank you, Elke.
Well, we have a few minutes here. I think we have a little bit of time to talk, and whether we want to make a formal declaration or if people think it's self-evident that staff includes board members that are in the building. So I will see if anybody has any thoughts on that.
And this is Elke. I'm reading the chat from Alicia Esty regarding students that are, like student teachers, for example, that are in schools. And we had the same question come up earlier regarding students that are being placed in hospital settings or healthcare settings as part of their rotation for training. And kind of wouldn't the same logic apply here? I don't know if that's worth a discussion.
Oh, I see what you mean, because they're in the environment. Is that what you mean, Alicia?
Yes.
Yeah, okay. Yeah, I mean, I don't want to insert my own opinion, but when I see that school staff, I guess we didn't define it, but a board member that's in the building supporting the school seems to be part of the staff, but
Dr. Burgess, there was a clarification in the chat from Randall Hudspeth that the original intent was to impact teachers who have prolonged exposure to students who may be asymptomatic carriers, and that the issue with healthcare students was because hospitals with known COVID patients were not allowing students in.
Thank you.
Well, I'm not seeing any other hands up at this time, unless we have anything else. Well, we may have something new in the chat. Dr. Turner?
Yeah, thanks. Another comment was that board members, while important, they certainly are not essential workers.
Okay.
So Elke, I guess the question would be, do we want to take this up for a vote either today or in the future, or
Yep, that's certainly something that we can bring to a vote at the next meeting, which is February.
Well, do we have time for that? This group is being vaccinated right now.
Right. So we don't have the ability to quickly pull that together as a vote, I don't think, but I would turn to Angela and Natalie. We could create that as a poll, just a simple yes, no poll on whether or not school board members are considered in the pre-K through 12 school staff and teachers.
Oh, and I do see a hand up, Karen Echevarria.
Dr. Burgess, if I may, I think the problem is that it's not being applied uniformly. Some regions, board members are being vaccinated now or have appointments to be vaccinated, and in other regions they're saying they're not. And so I think that's the problem I'm getting, because I'm getting calls on it, and I can't answer those calls because it's not being applied uniformly. And maybe that's just, as Elke said to me privately, maybe it's just that they need to, work with the health districts and make sure that the health districts are, providing that information uniformly across the state.
Dr. Burgess and Elke, this is Angela.
Mm-hmm.
We can do a vote on the fly if Dr. Burgess makes it a yes/no question verbally. Does that make sense?
Yeah, we can't undo what's already happened in some districts, but if we feel the need to give guidance, since our next meeting will be after we open up to a larger group of people, and this group is being vaccinated right now, I think that might be a helpful thing to give guidance to the districts that are not sure what to do. Does anybody feel differently? I'm trying. I can't see can't see people's facial reactions very well to tell. What do you think, Steve?
Well, I'm going to chime in that this is going to. This occurs every single day with a wide variety of any of the groups that are being vaccinated right now. There are different interpretations. There are decisions that need to be made by providers on the fly every single day, and people are doing it a little bit differently. And as you said, I think in the beginning of this, Patrice, in one of your comments, is that we can't police every single one of these individuals getting vaccinated. And so I sort of look at this and, this is the best guidance that we can give. We know we have limited supply. We do ask for, just like our conversation around clergy, that we do have that element of being on the honor system, that people try to fit into the groups that we anticipate them being in. So it's going to be, a little bit of give and take, and I completely respect that that you as CVAC members are getting lots of questions from your constituents about exactly where people fall. So I don't have the best answer for that, other than it's going to feel a little, I keep using the word fluid, and it's sometimes a little squishy, that we can't make everything crystal clear. But with that, if there's kind of intent that we need to reopen votes, we can do that.
I also think since we're already in this category and some people have already made those decisions, that I saw some discussion about just having each group clarify with their health district, that we might need to leave it at that, because making this after the fact when we're already vaccinating this group and some districts have gone one way or the other might be challenging. So does somebody want to tell me anything in the chat that would be helpful? Because I saw a few things fly by.
Yeah, Dr. Burgess, along the lines of your comment about needing to clarify in the here and now, Elizabeth Wakeman noted that there are college professors that are getting vaccinated, even though they are able to telework, apparently happening under the clarification of, quote, residential schools that you can see listed there in that bullet. Dr. Carter clarified that that was intended to be behavioral health treatment in other facilities that are providing behavioral health treatment. But I think it falls in line with your comments, your comments a little bit ago.
Can I just jump in? I was told 3 times this past week that my colleagues at the College of Idaho are getting vaccinated at St. Luke's. And I didn't think that was, I don't like them being vaccinated ahead of all the people we have going. So, but again, it's already happening. I would assume with residential, that means that colleges like the College of Idaho that consider themselves residential campuses are able to get vaccinated, but that professors at BSU, for instance, or the community colleges cannot. So all I know for sure is that there are professors from some schools getting vaccinated now.
Thank you for that. We do have a comment with from Amy Gamet that might help.
Yeah, and I just wanted to add to that too. We're hearing that even though we haven't included college, higher ed in this group. Do we have them defined anywhere? Because that might just solve that.
I do not believe college professors in the future discussion. Anywhere.
Sorry, there was a few people talking at the same time. That is something that we do need to take up, and at this particular point in time, kind of goes right in line with, and Alicia Esty just mentioned that higher ed faculty are still being discussed right now, that we have all of these, large swaths of the population that we're trying to address right now, with very limited vaccine. I think there are more conversations that need to be had. You look at the entire population of what makes up a university or higher education worker, that's a very, very large number. So I think there needs to be further refinement on what constitutes those that are at a higher risk that will help drive some of that conversation. So we don't have that for you today, but that will be a conversation for later.
Excellent, thank you.
Mm-hmm.
So we've started the conversation. We're starting to share some of the considerations there, and we will continue that conversation, it sounds like, perhaps the next meeting sometime coming up soon. Excellent, thank you. Well, we are right at the time where we would be moving into our wrap-up. So if we're ready to do that, I'll go ahead and get started on that. So today we heard some updates on the office hours piece, the remaining votes from the last meeting that when we need to, we take in between. And of course, the office hours help serve that to provide a venue for more discussion there for our members. And that is optional. And if we have those in the future, just so you know. And then we heard excellent updates on the national, state, and local levels to hear what's going on, right down to how the distribution and the allocation, distribution, and administration are going. So thank you for all those excellent details there. Of course, you're going to be receiving copies of all those slides so that you can refer back to them. And then we discussed the 4 votes that we had for today, and a little additional discussion on the school board members and college professors starting that conversation together. And that's where we're at for right now. So because we got all of our votes done today, I do not believe we have any next specific action items for our committee members at this time. So if we move on to the next meeting date, February 5th. So the same cadence as before, every second Friday for now, 12 to 2. So those are our next 2 meetings. And I think that's all that I have for my part. And again, I just want to thank everybody involved in making these meetings happen, the staff, the members, the extra voting that happens sometimes in between, and just everyone's input who's contributing considerations for everyone to keep in mind as we move through this very challenging work together. And with that, I'd like to pass it back to Dr. Burgess and Elke.
Great.
So I did see a few things fly by the chat that will be discussed at our future meeting. So if you look at the original slides, you'll see we talked about the groups that we're going to discuss next, and I think that will address some of those questions. But we keep everything in the chat, review it as we plan for the next meeting, and so we'll do our best to capture everything. And as you can tell, we keep evolving to try to answer your questions and get you the information you need. So thank you so much for your patience with us and for reading all that information. Elke?
Yes, I echo that. So I was going to say the same thing. We do have, just as a reminder, the ACIP 1C group is what we have sort of teed up next. Are we going to adopt what they say? We had a slide in the opening slides. It was on slide, for your awareness, slide 16 and 17 that you can see in your packet when you get it, that describes essential workers, and then persons aged 16 to 64 with medical conditions that increase risk for severe COVID. Those are going to be part of our discussion next time, as well, of course, as any further clarifications we need to bring. So we look forward to our next meeting in February. And of course, I know that you get a lot of questions and comments from your constituents, and we really appreciate you passing those along or letting us know so we can make these meetings more effective as well. With that, thank you all for being here.
Thank you. We're adjourned.
Thanks.